Hello to everyone. This is Dimitrios Kostopoulos, co-founder of Hands-On Seminars, and I would like to welcome you all for joining us tonight in this very special webinar where we have as a presenter Kevin Okamura. Kevin is a senior faculty of Hands-On Seminars. He's joining us actually tonight from Canada, where he lives and practices physical therapy. Kevin received his PhD degree from the University of Alberta, and he is actually a fellow of the Canadian Academy of Manipulative Physiotherapy. This is a very, for Canada at least, this is a very prestigious title for someone to have, since it's a very intense education, extensive education, training, and examination process for someone to qualify. And fellows are committed to provide the best quality of manual physical therapy in an evidence-based practice capacity. Kevin is also a clinical instructor with the University of Alberta, and many of you who are attending this webinar tonight, you may have attending a course with Kevin, and see here a list. We have a lot of people joining us tonight. I'll tell you a little bit of the logistics of this. Kevin will be doing a presentation. I have muted everybody at this point besides Kevin and myself, and if you have a question for Kevin, there is an actual hand that you can click and raise your hand, or you can type your question under the questions panel that is in the right hand side of your computer. With no further delay, I would like to introduce to you my good friend and senior Hands-On Seminars faculty, Kevin Okamura. Kevin, good evening. How are you tonight?
Good, thank you, Dimitrios. Thank you for the kind introduction there.
Excellent. And tell me, how is the weather up in Canada?
Well, we missed the nor'easter that you had, but we got a little bit of the remnants of Hurricane Sandy last week, but not too bad at all. It's could be worse. Could be worse. No snow yet where I am.
It definitely could be worse, because I don't know how many of the people who are attending the webinar tonight they are friends of mine in Facebook, but I have posted not only pictures of New York, but also the horrible condition that my house is after Hurricane Sandy. I'm actually staying in a hotel until they make repairs at my house. So, but anyway, what is in store for us tonight?
Well, I'm just going to be reviewing a few of the concepts of assessment when it comes to looking at the individual sort of segmental motion. What I find consistently seems to be a challenge when I teach manual therapy courses is the actual ability to determine whether or not a particular spinal joint might be stiff or whether it might be hypermobile or unstable. And most people know how to do a mobilization, but the actual skill of determining which segment needs to be mobilized and when to apply your mobilization or manipulation force is one that I find that consistently seems to be kind of a skill that's underdeveloped. So I'm going to go over that. We're going to talk about it in the context of a specific case study with a particular patient of mine that I dealt with.
Fantastic.
All right.
You can, Kevin, you can right click. You can right click and click next.
Can Can you see the start of the PowerPoint presentation here?
Yeah, just there you go. Click next. Perfect.
Great. Okay. So as Dr. Kostopoulos mentioned, I'm a physical therapist just based actually in Toronto, Canada right now. And as you mentioned, I'm a fellow of the Canadian Academy of Manipulative Physiotherapists and just hold a diploma in manipulation and spinal manipulation in physical therapy as well as my physical therapy degree. So we will talk about, as I mentioned, the idea of manual therapy for the lumbar spine and its relevance in patient treatment, and when we actually use these techniques and how do we determine whether or not we need to mobilize a segment. Our goal as therapists is to determine the appropriateness and type of manual therapy treatment that will best help the patient. The challenge to the orthopedic manual therapist is to differentiate which type of tissue and combination of factors might be contributing to a particular patient's problem. So that could be a soft tissue problem that could be contributing to their pain. It could be a joint restriction or joint hypermobility or instability. There could be some irritable nerve tissue, or there could be just generally some poor stabilization of a particular region, which all might lead to pain, or it could be a combination of even all of these issues. The other thing that we're always trying to weigh as manual therapists is how much weight do we give diagnostic test findings. So often patients might come in with an MRI performed that might show a small bulge or protrusion in a particular disc, and the patient is often very convinced that that's what's giving them all their problems, when in fact we know that there are many other pain-sensitive structures in the area that might actually be contributing to their issues. So that possible disc bulge could in fact just be more of an incidental finding. And then finally, the other challenge for us is to determine what type of exercises will best complement and assist this patient in achieving and maintaining optimal function. So those are sort of some of the challenges and the questions that I try to keep in the back of my mind when I'm interacting and dealing with various patients. So just a kind of a quick case study about an individual that I was recently involved with at my clinic here in downtown Toronto. Ms. M, we'll call her, is a 31-year-old TV producer with localized low back pain. She has a history of pain for 3 months. The onset was fairly gradual over a few weeks, and Ms. M attributed it to playing soccer. She had had some previous chiropractic treatments and some previous physical therapy treatments. They often gave her some short-term relief, but they failed to really give any significant long-term improvement. When I first saw her, her pain was daily, consistently very sore in the morning, would loosen up a little bit as things often do during the day, but with prolonged standing or prolonged sitting, the pain would often reach a peak of about 6 out of 10 and definitely be a limiting factor. The pain was not continuous, meaning it wasn't always present, but it was so frequent that the patient reported it happening all the time. Throughout the course of the day, it was commonly felt, and definitely the pain was quite intolerable at moments, and was managed with over-the-counter pain medications. So when I saw her, she discontinued playing soccer as her pain had worsened following the games, and she just felt like that was just too much risk to take on with trying to get through the day at work. Her pain was centered around the L5S1 level, but often radiated into the glutes, and it was usually more noticeable on the left side. And there was no prior significant history of low back pain. So just with some basic assessments, so the history could be a little bit more detailed, of course, just clearing up and ruling out other comorbidities. But I was satisfied that there was nothing really else significant from a medical perspective that I needed to consider. So just with the assessment, typically we'll start with some active range of motion, so basic cardinal planes, looking again for any restrictions, any moments during the movement where pain might have been, and any other sort of relevant observational findings. So with this particular individual, she had pain with spine extension. Her extension was about 80% of the normal range of motion. She didn't really want to push it past that. Flexion was mildly painful, kind of more of a real tightness and stiffness, but it was full range of motion. Left side bending was about 90% and painful. Right side bending was about 90% and she reported feeling stiff. So in addition to those cardinal planes, what we want to also look at are just some of the quadrant movements. So we could do a combined extension, side bend, sort of rotation movement to the right. We could add a little bit of overpressure to it. We could do the same thing on the left. And we can do the same thing with flexion as well. So the findings with Ms. M were that her right extension quadrant was about 80% and mildly painful. With her left extension quadrant, she had about 90% range of motion, and it was also painful. So these are the actual photos here. So a little more restricted going back and to the right on the right side, and some fairly centralized pain, a little bit of pain into the glutes and the SI joint with those movements. Left side was actually better in range of motion, but was almost a little bit more irritable, a little bit more painful.
Kevin, so that we can make this a little bit more interactive, let me just for a moment ask you a question. Let's go back to the quadrant testing. Basically, most therapists, they will check standard range of motion in the various planes, flexion, extension, side bending, rotation. Now, what would be the clinical usefulness of using quadrant kind of testing? What that will achieve?
Yeah, it's an excellent question, and thanks for jumping in there. Whenever we do fairly standard planar movements, if we're considering the anatomy and the movement of the facet joints in the spine, if someone were to do pure extension or pure flexion, ideally both joints would be moving to the same degree. What happens though is that neither joint can actually reach its full maximum end range position. So to achieve a unilateral end range movement at a particular level, we're forced to take that individual to kind of a diagonal quadrant motion. So just with this particular picture here, with that right extension quadrant, the right-sided facet joints will be taken into their maximum end range. Of course, the left side, because she's side bending to the right, those are going to be opening up to some degree, even though she is slightly extended. The left side will not be at full end range position as far as that individual facet might go. Similarly, we could have somebody flex and then add in some right side bend or right rotation to maximally open up the left facet joint. So the quadrant testing is crucial to achieving unilateral end range facet joint position. Okay. Proceeding then, so just with my assessment, I went through my typical scan, including some neurodynamic testing, so slump testing, straight leg raise testing. What I found with this individual was that the myotomes, or the key muscle indicators, were all normal. There was no real sign of significant fatigable weakness. However, that being said, she did have bilateral weak hip extension. So the right side was about a 4- out of 5, and the left side was about a 3+ to 4- out of 5. Dermatomes were normal, reflexes were normal, and all the neurodynamic tests and upper motor neuron tests were normal as well. Some of the secondary tests, looking at some SI joint approximation and gapping and SI joint mobility tests, were normal. No significant findings with that. Functional tests were also done. Just quick squatting, a little bit of single leg standing, balance, that kind of thing was also performed. With the single leg balance test, I'm not sure if it's visible on the slide here, but can you see how the left side, so on the right-hand photo, she's actually weight-bearing on the left leg. But you can see there's a little more of a lateral shift of the hips to the left and a little bit less control. So it's just a quick functional indicator of stability. If somebody has a little bit more lateral shift when they're trying to balance, and she's doing a little bit of a knee bend there while she's balancing, if there's a little bit more lateral shift going on, then often that can be indicative of some loss of stability. The left knee is quite a bit more valgus as she went through that range of motion as well compared to the right side. So again, potentially some weakness. I'm thinking of the hip abductors, the gluteus medius musculature, which is going to help support the pelvis. As far as tenderness, there was some palpation done over the L5-S1 segment, and that was found to be tender bilaterally. There was also some significant increased tone and trigger points within the erector spinae, the quadratus lumborum, and the gluteus muscles. So
can I interrupt you again here?
I find that most of us...
Kevin,
absolutely,
one more quick interruption and observation, maybe open the little dialogue there also. It was interesting that you mentioned that the hip extension, I think, on the left side, if I remember correctly, was kind of weak, and also when you had her support herself on that's right, when you did the single leg balance with a knee bend, definitely it shows weaker on the left side with that more of a sway there. And you said that the left side, not only the paraspinals but also the gluteal musculature, had presence of myofascial trigger points. So I'm kind of thinking how perhaps tightness of the gluteal musculature due to the presence of myofascial trigger points can may have contributed to the left gluteal weakness as a result of the tightness that would place the muscle at a biomechanically disadvantageous position.
Yeah, absolutely. I think you can get into kind of a vicious cycle sort of situation. So if somebody's a little bit weak, and as you see it, she's trying to weight bear and do a little knee bend on the left side. First of all, this look of lateral shift with more of a valgus knee position and apparent weakness in weight bearing corresponds to that resisted manual muscle test, like you mentioned, Demetrius. So in addition, the finding of tight and hypertonic and trigger point formation within the glutes is definitely going to create that shortening effect within that muscle. So you start to lose that optimum position when it comes to sort of length and tension on that sort of curvature. So by shortening a muscle functionally, it places those sarcomeres that form the muscle in a shortened position, which is going to be a biomechanical disadvantage then for them to actually be able to further contract with those cross-bridge formations. Further contraction is going to be disadvantaged. There's going to be minimal strength and power generation if the muscle's in a resting state of hypertonicity.
Kevin, I'm going to interrupt again just because, as I said, we want to make it a little bit more interactive. And actually, my very good friend, Rosalind Sofer, she has a question. So I have unmuted her microphone. Rosalind, you may go ahead and ask your question to Kevin. Rosalind, are you able to hear us? Okay. For some reason, we cannot hear you. So what I'm going to do is, instead of waiting, I will ask you to just type your question into the question panel, and I will ask that question to Kevin as soon as you type your question, okay? All right, thank you. Let's move on.
Did I adequately expand on your point, your observation, Dimitris?
Yeah, absolutely. Thank you.
Okay, great. Thanks. So as I was mentioning, kind of a common point of confusion, and if I sort of relate back to when I graduated from physiotherapy school, my question was often, okay, I know how to do some basic range of motion testing. I know how to do a lumbar scan to screen out any significant neurological findings. But in the absence of anything really significant and positive, where do we go from here? So how can we determine which segmental levels, if any, are actually problematic in this person? And then how can we go about treating these segmental restrictions most effectively? So the answer to that is that we can perform passive physiological intervertebral movements, often just called PIVMs or PPIVMs, and we can also perform passive accessory intervertebral movements, PAIVMS, to help determine these biomechanical segmental restrictions. So the PIVMs can be done bilaterally or unilaterally, so you can have bilateral flexion or extension, for example, or unilateral flexion or extension. You could also add in bilateral or unilateral rotation or side bending. The PAIVMs can be performed with the patient prone, or sometimes you can just add an extra glide or overpressure at the end of a PIVM. So in a prone position here, you could simply try to stabilize one bone of the segment, and you could try to create another glide either inferiorly or superiorly relative to the stabilization bone, which is really creating what we call an accessory glide. So this is a movement, again, that that individual could not produce on their own. So only by the application of force by us can we introduce an accessory glide. So this is just a quick demonstration of the performance of a bilateral flexion PIVM at about L2-3. So I'm just cradling the knees, and I'm palpating with my right hand there the interspinous space between L2-3. And we're just basically feeling for motion as we kind of swing and rock the legs back and forth gently. So we should feel a bit of a gapping between the two vertebrae in that interspinous space. Here would be just bilateral extension PIVM, again at L2-3. So as you can see with my left hand, I'm still kind of cradling the knees, and I'm taking that spinal segment back into extension. So the legs I'm using as kind of a lever to extend through the hips, through the pelvis, and actually generate an extension motion at L2-3. Now, we can proceed to doing a unilateral PIVM if we like at this point. So Ms. M is lying on her left side, so I'm palpating and assessing the top joint, the right joint here in this photo. Looking at L4-5, I'm producing a unilateral extension PIVM, or a unilateral sort of extension glide if I add a little bit of overpressure with my superior hand. So I'm in effect approximating the right L4-5 facet by using the top hand to move the L4 superiorly. Here I'm doing a unilateral flexion PIVM glide of the right L4-5. So as the arrow is showing with my left hand or my inferior hand, I'm producing a glide inferiorly on L5, thus opening up or gapping that right L4-5 segment. So just bears reminding everybody, when we're naming motion at a particular segment, we're always naming that motion in relation to what's happening at the superior bone of that particular segment. So even though I'm using my left hand to move L5 in a downwards inferior direction, the effect is that L4 relative to L5 is actually flexing or opening up. So if you consider a lumbar facet joint, it actually only has glide available in two directions. There's a posterior inferior glide, which is the glide associated with an extension type of movement. And there's an anterior superior glide, which is the glide associated with a flexion motion. So if we think about all the movements in the spine, if we're rotating to the right, what that involves is a combination of an inferior glide on the right of the L4 bone on L5 and a superior glide on the left of L4 relative to L5 facet. So again, just remembering that the direction of the glide is always named in relation to the superior bone of the segment. Are we okay with that? Any questions there so far? Everybody's happy. Demetrius, are you there?
Yes, it seems that I don't see any questions right now from anyone, so, and everybody seems very attentive.
Great, thank you. So it's by performing these PIVMs and PAVMs in combination that really we get our information about the status of a joint. So if a joint feels like it's not gliding as well as it normally should, so often what we'll do is assess several joints in a row. So I could assess the L5S1, move up to L4-5, move up to L3-4. I'm looking at the joint motion at each level, and I'm also kind of comparing the relative motion of one facet to another facet. So if I feel something might be a bit stiff or stuck with its glide feels like it's a little restricted, or it doesn't feel like it's moving quite as easily as the one above or below might be, then I'm making note of that. So that could be just a finding that I want to write down. But that might be a joint I might want to target for mobilization or manipulation. Conversely, if a joint feels hypermobile or potentially even almost unstable, then stability testing may be indicated, and that joint would not be appropriate for mobilization or manipulation. So sometimes I think individuals who might experience their back seizing up on them, they might have their back lock or go out on them, as they often say. Sometimes I think what's going on there is there's a hypermobility or instability at a particular joint. If something's unstable, then that joint can glide a little bit more than ideally we'd like to see, and the inert passive structures like the ligamentous support system of the capsule maybe aren't doing a good enough job. Sometimes I think that facet might get stuck at one end of its range. That person might go into a chiropractor or even a physiotherapist, have a spinal manipulation done, feel a great deal of relief because that joint has been unlocked. However, if there's an underlying instability issue and they go back for a second treatment because they've been told to come back and they get another manipulation done, often the experience will be that they feel worse following that second manipulation. And I think those are the cases when the joint might be hypermobile. Maybe it did actually get stuck at one point. Now that it's unstuck, it's just hypermobile and loose. So what we don't want to do is a technique that introduces more motion there. So that would not be an appropriate joint for mobilization or manipulation if it's hypermobile. Those joints instead need to be stabilized via strengthening exercises. So with this particular case study, when I performed the PIVMs and the PAVMs, Ms. M was found to have a stuck right L5S1 facet. It wasn't moving in a posterior inferior glide direction. So she actually had a little bit of a loss of extension at the right L5S1. Additionally, she had a hypermobile left L4-5 and a left L5S1. So if you recall back to the extension quadrant range of motion finding, she actually had a little bit more range of motion going to the left than she did to the right. And I think that hypermobility allowed her to get further into that range. However, it was a little bit unstable actually, and that joint was getting irritated and inflamed from, in fact, moving a bit too far. So it was decided by me that her right L5S1 segment should be mobilized to restore that extension PIVM or that posterior inferior glide loss. So prior to mobilizing the spine, though, what I always do is lock the spine. So locking is just a little setup technique to make the mobilization or manipulation more effective. It means that the joints above or below the joint to be treated are positioned in a way to minimize the chance of unwanted mobilization force from impacting those other joints. We want to be as specific as possible with our force by locking and tightening up the joints above and the joints below while leaving the joint we want to treat in neutral. We can ensure that we're reducing the risk of unintentionally mobilizing a joint above or below the desired joint we want to treat. So I'm not going to get too much into the specifics of that. Here's just a photo of me using her left arm. I'm pulling it to induce a little bit of right rotation, and I'm locking the spine there. I'm using my hand to palpate for motion to occur with my index finger at the joint above the one that I'd like to treat. So when I feel motion there a little occur, then I know that I've tightened up all those joints above the one I want to treat. Then I just offset the legs below, introduce just a tiny bit of flexion if I need to tighten up or lock out that bottom lever. So again, I'm making sure that no joints below the one I want to treat might be inadvertently mobilized. So as I'm sure most people are aware, the mobilization can be done from grades 1 through 5. Once the spine has been locked and my treatment position is set up, I can simply apply that graded mobilization of my choice to my patient. I don't have to reposition at all. I can just stay in that one position and progress my grades as I so desire. The mobilization force could be applied in 3 different planes. So you could do a distraction of the joint surfaces. So that would restore both the anterior superior glides and the posterior inferior glides. So you get a restoration of either unilateral flexion or extension with a distraction movement. So here's me just introducing kind of a distraction force. I'm using the pelvis as a bit of a lever after my lock, and I'm mobilizing in a direction consistent more or less with the plane of her femur, or the direction of her right femur in that picture. I could also introduce a posterior inferior glide of the joint surface, which would restore the extension. So the pelvis could be used again as a lever, and I can use that to push the inferior joint superiorly, thus creating the relative extension of the top joint. So again, I'm coming up a little higher towards the iliac crest, which just gives me a little bit better purchase, and then I can take that joint to the barrier, the R2 barrier, and I can do a grade 4 mobilization at that barrier, or if I want to, I could extend that into a grade 5 manipulative thrust. And then the last direction of motion that we could do in that level is an anterior superior glide of the joint surface, which would restore the relative flexion of that joint. So again, I like to use the pelvis if it's not irritable for that individual, and I'll take that pelvis and use it as a lever to glide the inferior joint in a posterior inferior direction, thus creating a relative opening or flexion of the top joint.
Kevin,
so
I
that's
think
what I'm doing there. So a little bit difficult.
Kevin,
Yeah.
I think this is a good
Yes.
point to just ask you 2 questions that have been expressed by 2 of the attendees. Let me start with the second question, actually, which may be very relevant to what you were showing right now, which was asked by Christopher Sbertoli. I probably don't pronounce the name correctly, but Christopher says, when you test unilaterally, do you actually perform the testing in a superior or inferior direction? When you test unilaterally, do you actually perform the testing in a superior or inferior direction?
You could do either. Is he specifically, thanks for your question, Chris, is it specifically with an extension type of movement or a flexion type of movement that the question was in relation to, or generally speaking?
Actually, Christopher, I have unmuted your microphone, and if you would like to elaborate more, you can. Christopher, are you there? Yes, I can see that he's there, but maybe his mic is not working. Okay, just the testing. If it is a PA type of testing.
Okay, so going back to prone position test then?
Yeah,
or
probably.
sideline?
Yeah, probably he's talking about the posterior anteriors from a prone position.
Mm-hmm.
So when you did the prone PA, he says when you test unilaterally, do you actually perform the testing in a superior or inferior direction? So when you do the PA, the direction of your force, in other words.
Yeah, absolutely. You can try to create a relative superior or inferior glide in that prone position. So you could do a straight PA, which would create a little bit of a distraction at the facet. That's fine. That's no problem. You could also try to move the specific facet along the plane of the joint by either pushing the bottom bone up. So if we're talking about the right L4-5, for example, I could try to do a little bit of a stabilization of the right L4 transverse process, and I could try to get in on the right L5 transverse process and glide that in an anterior sort of superior direction, superior for our purposes, creating a relative extension type of movement at that joint level. Or I could take L4 and push it inferiorly while holding on to L5, which would also create a relative extension movement. So it's actually optional. You could do one way or the other way. You could move one bone up, one bone down, and it doesn't really matter too much as long as your relative movement is the same.
Then Rosalind Sofer asked at some point, this seems to be a chicken egg phenomenon. Does a facet problem create the muscle imbalance or vice versa?
Yeah, that's an excellent question, Rosalind. The answer is I don't know if we can really make a definitive statement on that. I think often there's a lot of myofascial imbalance through poor posturing. So sitting in with poor posture and so on, there's that inhibition of the glutes that tends to occur. There's the tightening effect that tends to occur with the quadratus lumborum and the psoas. So if that goes on long enough, then definitely I think it makes sense that an individual facet might get kind of stuck or locked. Then once that facet motion ceases to occur normally, then you can get a little bit of a pain response or an inflammatory response perhaps, creating more muscle tightening, which is then going to create a bit more loss of range or movement at the facet. And that vicious cycle can go on and on. Also, someone can easily lift or carry something or twist and bend at the same time, and that joint might glide to its end range and then get stuck there, and then you get that muscle spasm and tightening as a response to that too. So I think both scenarios are possible, and a lot of the time I don't know which one maybe occurred first, and ultimately, while it might be nice to know, the treatment is probably going to look at all elements together. So the treatment would still want to address myofascial tightness and myofascial trigger points. We'd also want to ensure that the facet joint motion's been restored. Then we want to give them strategies to help avoid this thing from happening again in the future. So everything from posture education, lifting education, to, of course, some effective core strengthening techniques.
Super. Very good. That's for now, and let's move on.
Okay, great. So just going back to this photo that's up right now, this was the performance of an anterior superior glide on the right L4-5 to restore flexion. So I was using the pelvis as a lever, and my mobilization force is more or less along the direction of the arrow indicated there, and you can just imagine if I'm using that pelvis as a lever and I apply that force, there's going to be a bit of an opening effect of that right L4-5 joint. So after performance of our technique, what I like to do is just go back and then retest the individual's motion with them in a neutral position again. So I make sure that they're unlocked, get back into my neutral position that I had them in when I was testing at the very outset. And then I just want to see if my technique was actually effective. So was that hypomobile joint, stuck joint, does it seem to be gliding better? So that's confirmation that I either did my job well or didn't do my job well if I feel that that joint is moving more. There's a link that I think, Demetrius, you had shared
what we're going to
with
do,
the participants.
Actually, what we're going to do right now is I'm going to take back the screen there, and while I'm going to be showing to everybody this brief video that Kevin has prepared, Kevin will be explaining to all of us what exactly we are actually viewing. So, Kevin, go right ahead.
So hopefully that's coming through not too choppily. This is just basically a review, a quick performance of everything I just discussed. So here I'm just doing some bilateral flexion PPIVM movements. So just using the legs, flexing through the spine, and just feeling for symmetrical motion there, noting any pain or restrictions. Now I'm getting into bilateral extension. So again, it's not a huge motion. It might look kind of similar just with the way the video is here, but it's a very small movement available, and I'm narrowing that space. Now I'm going into a unilateral PIVM on the right L4-5 joint. I'm using my right hand. Pretty sure this is my extension PIVM that I'm going to be performing. I'm using my right hand there, and I'm creating kind of an inferior directed glide of the top bone of the segment. So L4 is going in an inferior direction, closing down that joint, creating a relative extension associated movement there. Now I'm opening up the joint. You can see me using my left hand on the pelvis, using that as a lever to create a relative flexion movement of that right L4-5. So doing a unilateral flexion PIVM. At the very end there, what I do, it's hard to see here, is just a little bit of an extra overpressure with the glide to get the accessory movement feel as well. So now I'm going back. I've decided that that right L4-5 joint feels a little stiff and restricted. So what I want to do is an extension mobilization at that joint. I'm going to perform that lock I was mentioning earlier. So I'm using her left hand as a lever to induce some rotation of the spine joints above the level that I want to actually treat. So those joints are all tightened up. They shouldn't be experiencing any significant excessive force. I'm going to now just offset the legs here to lock out and tighten up the tissue below the level I want to treat. So there's a ligamentous tightening effect. And the foot is just kind of hooked in behind the knee there. You can see my videographer in the mirror there. And now I've isolated and I'm ready to do my mobilization on that joint. So I'm going to do an extension direction. I'm going to use that pelvis again as a bit of a lever here. So I don't actually have to worry about keeping my fingers on the L4-5 segment because I know that I've localized my technique to that level through the lock. So I can just actually feel free to use my forearm on the pelvis, just around the iliac crest. There's a demonstration of a distraction mobilization force. So I'm pulling along the line of the femur just as another option that can restore an extension loss as well. Now I'm going back to the extension position, taking it right to that R2 barrier. And I just didn't really see it there. I just did a grade 5 technique at that right L4-5. And then I just rechecked at the end once my technique was finished, just to ensure that motion there was restored and that the joint movement was feeling better.
This was really very nice, and it really looked like a textbook case. You made it look very easy.
It is one of those things, you know, that once you just get that practice down, it goes from being a real sort of mental exercise of what needs to be done, you know, just a very automatic process. So I remember learning these techniques and felt at first that I couldn't feel anything and that I was never going to get it. And slowly, after chipping away a bit, I was starting to think, okay, I might be feeling something now, but it definitely wasn't an instantaneous occurrence for me. It was a lot of hard work and a lot of practice. What I often say is that most of us, we want to retreat back to techniques that we're comfortable with. So a lot of the time, you know, we learn modalities in school. We can ultrasound people, we can put some TENS on them, and we can do some exercise, and that can be effective and helpful, but it may be missing part of the picture. So developing these manual therapy skills, while it can make you feel less than proficient at times, by learning and sticking with these skills, we really can start to get more and more people better and better. But it definitely takes something to kind of push through that feeling of not being adequate enough at the beginning, and it was definitely something that I experienced. I remember the first Monday after doing a course, learning how to just assess the spine like this, I made a conscious decision. I said, I don't like this. It feels hard, and I feel like I'm no good at it. But it probably means it's something I should try, because unless I put myself out on the skinny branch and really force myself to do something I'm not comfortable with, I'm never going to learn to get, and I'm never going to get better. And I knew that my ultimate goal was to try to be as effective a manual therapist as I could be. And I knew that I was missing part of it. And by learning these techniques, learning how to pick up a restricted segment, it really helped to sort of complete that idea I had in my mind when I entered physical therapy school. And the results are that I'm able to more effectively treat and manage a wider range of patient problems. If I would have stuck in my comfort zone and only maybe just did some soft tissue work, some modality work and exercise, I would have helped a tremendous number of people over the years. However, there would have been something that I could have been missing, and often those little set restrictions, if they're not addressed, they can keep hanging around and hanging around.
Right.
So,
right. Absolutely.
Easy as it might have looked. Yeah, and I'm sure Dr. Kostopoulos, you can you know, second that. But as easy as that might have looked, that was, you know, a lot of frustration and practice to get to that point.
Kevin, you have a few more slides before you complete, or this was the final slide?
There is just one or two more, actually.
Let me just give you back the control so you can just click OK so we can see your screen.
Okay.
There you go.
So just to kind of wrap up, that looks okay there right now?
Yeah, perfect.
Okay. So just continuing and just finishing off the case study here. Once the segmental motion at that level, so actually I think I'd written L5S1 was a restricted one. I might have demonstrated L4-5 on the video there. But once the segmental motion was restored and monitored, and occasionally sometimes it might get stiff again, and I did have to go back a couple of times and mobilize. Phone going off?
Yeah, it's okay.
I also did go in and treat the myofascial trigger points. So as I was mentioning, I think to Rosalind's question, definitely both elements need to be looked at in a and didn't worry about the myofascial stuff. To your point, Rosalind, that myofascial restriction, had it continued, it probably would have just caused that joint to stiffen up again. So I really want to make sure I'm addressing all the potential tissue types in the area that could be contributing to the issue. And then the key to maintaining the desired biomechanics and the reduction of the trigger points is effective and safe core stabilization and strengthening exercises and postural education. So that's, again, time and time again, if you look at the scientific evidence, the most significant difference in terms of restoring patient health and function is a combination of manual therapy and exercises. So if they don't continue on with their exercises after you've done, you could do a bang-up job in terms of manual therapy, but unless they're doing something to change what brought them into your clinic in the first place, then chances are they're going to experience a recurrence sooner rather than later. So that's definitely a part that I like to emphasize. So with consistent hard work at her exercises and regular therapy visits, so Ms. M came in twice a week for probably about 4 to 5 weeks. Her pain gradually diminished. Upon last visit, she had returned to soccer for the first time in almost 5 months, had played twice actually in between visits, and had experienced no significant soreness or pain afterwards. Work is pain-free. Occasionally there's a little bit of a stiffness, or every once in a while there might be just a little bit of a trace, little twinge. But the great thing is she's been able to manage her pain through maintaining these functional core strengthening exercises as part of her fitness routine. So moving forward, she's really committed to incorporating some good strengthening and biomechanics and body mechanics into playing her soccer. So she's not only just playing soccer, she's just really creating a nice kind of balance to what she's doing. And that is it. That is the end of the case study, end of the presentation for now. So thank you all for your attentive listening, and I'd be happy to answer any more questions if anyone has any more questions.
Sure. Let's see. If anyone has any more questions, please. Okay, yes, we do have actually. Let me see. Yeah, we do have a couple of questions. Let me just find them out here. All right. No, actually, Rosalind Sofer, again, she just made a comment that I understand treatment is multimodal. Personally, do you start with the joint or with the soft tissue? But, you know, you already answered that. It's, you know.
Yeah.
And I told her also that this is a debatable issue as a battlefield of people in the manual therapy world, whether they are the myotherapists or the popping therapists who have a difference in opinion on where to start.
I'll say this. I'll say this, Rosalind. When I first learned how to do spinal manipulation, I got a lot of kicks out of doing it, and so I would start with spinal manipulation. As I've probably matured a bit more as a therapist, I tend to probably start more with myofascial. But ultimately, it's debatable, and you could probably go either way, like Dr. Kostopoulos said.
Kevin, thank you so much for tonight's webinar. It was very, very informative, and I know that everybody has been very attentive here. And those of you who...
You're welcome.
Okay, and yeah, those of you who want to actually see Kevin teaching, Kevin is teaching several, all actually, of our MCMT, the courses that are in the MCMT curriculum. You can call hands-on seminars and you can find out which of the courses he's teaching, where and when. And also make sure that you register for the rest of the webinars we have in store for you. Amazing webinar for the kinesiotaping method with Andrea Volkenberg. Now hands-on seminars in collaboration with the International Kinesiotherapy Association, offer you the prerequisite requirements for you to become certified in kinesiotaping method. So you can register through the Hands-On Seminars website. And once again, thank you all for attending tonight, and thank you, Kevin, for presenting tonight. Awesome presentation.
My pleasure. Thanks for taking the time to listen to me.